Hello and welcome everyone to the National Council of Urban Indian Health's Peer-to-Peer Solutions Center on HIT Technical Assistance Support. My name is Tiffani Stark and I am Nikui's Public Health Program Manager and I'll be your host today. We would first like to thank you for volunteering your time to participate in today's session. We truly appreciate your willingness to share your UIOs experiences with HIT and EHRs. We do understand that this could be a sensitive yet very important topic, especially during a pandemic. This is a safe space and feel free to share as much as you feel comfortable sharing. There are no right or wrong answers, and we know everyone's in a different place with capacity and with their HIT and EHR experiences. So this is a chance for all to learn from each other. And so next slide, please. Again, we are very pleased that you could join us today. Your feedback is very important and will allow us to further understand your HIT and EHR needs and how to support them. If you have any IT difficulty during today's session, please chat directly to Comms and Events, and Lamar can further assist you. And finally, if you could, please enter in your name, UIO, or external organization, and any tribal affiliations into the chat box so that we can get to know each other and count your attendance. And just before we get started, we would like to review a quick housekeeping items. So please, if you have video capability, enable your camera. This helps to create more of an interactive environment. And also please note that your microphones are muted, but you have the opportunity during our open discussion to have any questions answered. You can also raise your hand at the bottom if you'd like to be called on, or just unmute if there's silence and pop in. Our chat box will be monitored as well, so please feel free to drop any questions or comments throughout the presentation, and we will address them at the designated time. And just to note, this session will be recorded for educational and quality improvement. Your answers are definitely vital to help us further support you in your HIT and EHR needs. And we would like to also have an acknowledgement. So this project is supported by the Centers for Disease Control and Prevention of the U.S. Department of Health and Human Services as part of a financial assistance award totaling $100,000, with 100% funded by CDC and HHS. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by CDC or HHS or the U.S. government. And just to provide a quick overview of Nikui for those folks who are new. So our organization is a national nonprofit that is devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives in urban areas. We represent 41 Title V UIOs under IHS in the Indian Healthcare Improvement Act. We strive to improve the health of over 70% of the American Indian Alaska Native population that lives in urban areas, supported by quality, accessible healthcare centers. And as you could see on the screen today, our agenda, again, welcome. We would like to move into our introductions for our speaker today, and then we'll move into our open discussion and wrap up with the evaluation reminder, as well as some upcoming Nikui events. So as mentioned, here is the evaluation. So if you wanted to take out your cell phone and pull up the camera and hover over the QR code, you could certainly do that. And also the link as well. And this will be provided in a follow-up email after the event too. So you could always provide any responses that will help with the HIT and EHR support that you need. Next slide, please. And so now I just want to provide a brief overview of the HIT project. So under the Strengthening Public Health Systems and Services through National Partnerships to Improve and Protect the Nation's Health through the Center for State, Tribal, Local, and Territorial Support, CSTLTS, the National Partnership Branch. Next slide, please. And so for our Nikui technical assistance goals that are focused on the HIT, we do have our contract with our subject matter expert, Mr. James, who is on the call. We did have our virtual dialogue back in May which we were able to collect a lot of valuable information on our UIO needs. And then also now moving forward with the technical assistance with our subject matter expert through these monthly calls, or as well as one-on-one, which you could definitely utilize through our TA submission forms on our site. And Micah will drop that link into the chat too. So that's definitely important if you would like some one-on-one time as well. And here's just a pie chart that shows the breakout of the EHR capacity. So as you could see, the majority of the EHR is using commercial off-the-shelf systems, with 37% using our PMS only. And just to note on our subject matter expert, so the HIT technical assistance will be provided through trainings based on our UIO needs, and designing and planning, training webinars targeting our UIO frontline healthcare workers, administrative as well as executive staff that are using HIT. And also, as mentioned, providing one-on-one technical assistance, which could definitely be utilized through submitting the TA submission form. All right, so now I would like to introduce James Spillane, who's joining us today as Nikui's HIT subject matter expert. So James is the CEO of Health IQ. He has an extensive knowledge in HIT and EHRs, and he has served on several national committees such as OIT Information Systems Advisory Committee and faculty for IHS IPC Collaborative. So at this time, I would like to hand the presentation over to James. James?
All right, I guess next slide. All right, can you guys hear me all right? All right, perfect. All right, so I get a little long-winded here, so I'll try and make this quick within like 30 minutes. Well, my name is James Spillane. I'm a quality improvement advisor. I do a lot of work with patient-centered medical home models all around the United States, working with urbans, IHS facilities, and tribal 638 tribes. Here's a picture of Kodiak, Alaska, where I kind of started out about 15 years ago. They were one of the first folks in the nation to meet all of their Gipper measures, and they did it with very remote villages with lack of access to resources. They somehow pulled it all together and met all their Gipper quality measures. So that's what we're going to talk about, is what those journeys kind of look like and how to put the pieces of this puzzle together. So we're going to look at a kind of a high level all the way down to a small level all at once. Next slide. So one of the first questions I like to ask folks is, what is your mission statement? It's kind of hilarious because a lot of times you can just point blank ask someone, like as you're passing a hall, and they don't know their mission statement. A lot of times even like the C-suite folks don't know their mission statement. So it's always good to put it up on the wall and kind of refamiliarize yourself with it, because most mission statements, if you go to like the next slide, I'll give you a good example of one. This is like Little Traverse Bay Band, I believe. But basically, they kind of all have the same thing. You're going to provide quality healthcare. A lot of them have something to do with, you'll see the word holistic. When we look at tribal healthcare, we look at Indian healthcare in our Indian model. It really is mind, body, and spirit. So we're not just like an urgent care clinic, or we're not just seeing you for that sprained ankle. We're seeing your whole body, and that's what we really want to get to when we provide that quality care. And that's what separates us from the others out there. Next slide. So one of the things too is it's kind of a mindset. Like healthcare, you see the word healthcare and it's thrown around so much now, and everybody's in healthcare. It's like 22% of our GDP. It's kind of becoming like this weird word. And one of the things I would like to stress, like especially in Indian country, is we need to get back to like health caring about the holistic, the person as a whole, outside of our facility. Next slide. So some of the things that we'll talk today about is we're going to talk a little bit about what the current state of healthcare is, what is our care model for Indian health. We're going to use words, you probably hear these words all the time: GPRA, Governmental Performance Results Act, and patient-centered medical home. We're going to look at what a change package looks like. So all the different pieces of the puzzle that you kind of have to change. A lot of times people think it's just this each EHR. It's not. It's roles, responsibilities. It's who rooms the patient, who does what, etc. We'll talk about what training looks like, care team configuration, clinical information systems, and then how you kind of put it all together and kind of what it looks like. Next slide. So like I said, I get to go around the country working with various different projects, whether it's meaningful use or improving patient care projects or quality improvement projects. So I've seen a lot of like what works, what doesn't work. I've seen all these different tribes and urbans and IHS facilities, and you kind of see like, oh, these are the common denominators that we can do in the care that we deliver. So next slide. So the first thing is we're going to talk about your healthcare system. So your healthcare system is, it's a tool at the end of the day. If you really look at what we're doing, our EHR is a tool, our healthcare system and our design of our healthcare system is a tool. What are we doing? We're meeting the need of our patients, right? So that would be the front facing. So when I look at a tool, I want to design, all right, how do we design a better front facing? How do we interact with the patient better? But also we look at how do we interact with the capability. That capability is your licensures, that's your knowledge, that's your skill sets. It's our doctors and our nurses and our MAs. So what we're going to do is try to make the front facing better fitting, and then we try to make the healthcare system itself and the EHR better fit for you guys. And a lot of times, I mean, honestly, what we're doing is we can hammer, a hammer is a really good tool to use here because you can hammer in a nail, right? But a lot of times is we're doing it with like a brick, and there's a better way. And so that's what we're going to kind of talk about a little bit. Next slide. So when I travel around the country, these are a lot of the same similar things that I see over and over again. So much so that I just actually leave it up here because you could probably look at what you guys are doing and probably pick a couple out of here. So I just kind of leave this up when I do a review of systems, but we have trouble with our cycle times. We have problems with getting our schedules too far booked out. A lot of times if you have emergency departments attached, patients will go there because they know they can be seen rather than getting scheduled 3 weeks out for their primary care provider. A lot of folks don't have their care teams properly configured. And if they do, they don't have the roles and responsibilities kind of lined out the way they probably should be. You'll have you'll have doctors faxing stuff and making the phone calls. It's like, no, let's get to the top of our licensure and see if we can find other roles and responsibilities of other people to do that. But a lot of times there's like little or no case management outside of the facility. So it's kind of like we're just acting as they come in, we're doing the chief complaint. And how do we get better at sending out those memo due text messages and those PAPs and those colos and all that stuff? So what does that look like and what tools do we use? And then the clinical information systems, a lot of them are, they're all over the place. So there's always a pro and a con to every single one of them. And so this is what we got. But a lot of times what I notice is people aren't trained on them or how to utilize them fully. Like they aren't even using iCare or other tools like that they have right on their systems, or they're not using it to the capacity. So next slide. So let's go back to what the care model is for Indian healthcare. So this is it. This is kind of, and if you notice, there's a big circle around the outside of community. So we have to have like community outreach, community tie-in. A lot of folks do this in various different ways, whether they have like grow your own programs where they grow vegetables and and work with various greenhouses. Other people do counseling. Other people have baskets that they give out to folks. But basically, we start with that big circle first and think, okay, and then within there, we have our healthcare system. And if we're doing these things correctly, we have an activated, engaged patient, and then we have a proactive, prepared care team. And that's the key word, prepared. They are already before the patients, before they come in. And just like, real estate, they say location, location, location. In healthcare, it's really relationships, relationships, relationships. The better you create that relationship with that patient, the more likely they are to actually listen to you when you say, hey, you really need to get this colonoscopy, we're really worried about you. They're more likely to adhere to that. Next slide. So this basically comes from the model that predated it, was the chronic disease management. So it's kind of like this was the first one. And the reason that this exists is because, mainly because of diabetes is where this really came from. But if you look, this original model kind of has some cool throwouts like tribal smoking policies, housing, casino, food access, homegrown project, walking past. It's kind of showing you more broadly what that community outreach portion looks like. So this is kind of the DNA of Indian healthcare, as you will. This is where it kind of comes from. So these are the things that we kind of want to be looking at as we start to build our tribal health clinics. All right, next. So here's the other word that we would talk about, and you probably talk about too, Gipper, the Governmental Performance Results Act. It came out by the Clinton administration in 1993, I believe, or around that time frame. Basically, as a hey, if you're receiving federal funds, we would like you to report these quality measures. So the good thing about Gipper is it's multi-domained, right? So you have cancer, you have behavioral health, you have STDs, you have immunizations, you have diabetes, heart disease, all kind of bundled into one. So the thing is if you're doing pretty good at your Gipper, you could pretty much use that as a litmus test that you're doing pretty good at delivering healthcare. Next slide. The other word you'll hear a lot about is patient-centered medical home model. That really is at the basis of what Indian healthcare models are. We're a patient-centered medical home model. So we're supposed to be delivering high-quality, cost-effective primary care using a patient-centered, culturally appropriate, team-based approach. So that's the words there on the Centers of Disease Control Prevention. So patient-centered medical home model, how do we deliver that? What does that look like? And then how do we utilize our tools to help us deliver that? Next. So I always like this slide, and I always like to share this slide. There's folks on the line right now probably seen these slides a million times and probably sick of them by now. But I really do believe you should measure the things you care about. And if you're not measuring, you don't care and you don't know. I can tell a quality-oriented organization just by the fact that they're probably sending out their quality measures once a week or at least every other week, not quarterly or not at the end of the year. Other folks, they run the report maybe at the end of the year. It's because they have to, not because they want to. They probably have a grant that is due or a federal requirement. So we really need to get into the habit of knowing where we're at and what we're doing and where our weaknesses are, where our strengths are. Next slide. So let's get into some of these things that we can do and kind of what a change package looks like. So here we have one site right here. The only thing they did was deploy clinical reminders, and within a short time frame, I'm actually talking a couple of months, you can see that all of their measures pretty much started to go up just by having one new tool on their electronic health record. So this site in particular had a little red clock that would go off and say, you are due, this patient is due for their foot exam. This patient is due for their diabetic eye exam. Just that little tickler was enough to have, to engage the providers to actually start to, hey, I need to do this while you're here. Even though you're coming in for the sore throat, why don't we go ahead and knock this out real quick? Next slide. So here is that change package. So this is probably one of the more important slides I have, and I really like to stress this when I'm working, especially with executive suite members, because a lot of times we get stuck on thinking, oh, well, we'll get a new EHR and that'll solve all our problems. Or, it's the EHR that gets blamed for a lot of things. No matter which one it is, there's always going to be limitations to that. But what I want you guys to think of it is there's a million things that we can do that have nothing to do with that technical aspect of it, or what we call clinical information systems. There are so many other things we can do, like job descriptions, roles and responsibilities, process analysis, gap analysis, that we can go, hey, why don't we move this over here? Why don't we? So when we start that, you kind of start with an assessment. You make sure that it's strategically aligned with your leadership, your mission statement, stuff like that. But The most important is that you have leadership buy-in. They believe, all right, we're going to go down this improvement trail together. We're all in on it. And you identify what are you going to change, and does this go with our values and our core and our mission? Then we go over and we actually get into phase 2. And phase 2 is where you actually start doing stuff. So you configure the care team the way you actually want the care team to be configured. You configure the roles and responsibilities. Maybe you want the MA giving shots. Maybe you want the only nurses giving shots, vaccinations, etc. You come up with a good communication plan, like we're going to meet every Wednesday at 4:45, everyone all for our improvement meeting. Here's what we're working on. Here's the projects. This is what happened this week. You look at your empanelment. So these are your patients. These are your patients, because trying to take care of 2,000 patients all at once might be hard. But if you break that down into bite-sized pieces, like I'm going to manage these 600 and you manage these 600, and you're the case coordinator for that, and you're the case coordinator for this. Clinical information, can we tweak our systems? Can we tweak our templates? Can we tweak our notes? Can we make that more automated? Can we do quick notes? We'll look at access and basically continuity. Can the patients get to see you? Do you have transportation? Because if they can't get to see you, all this other stuff is moot point. So we got to make sure they have pre-open access. Transparency of improvement. So a lot of sites will put their measurements out on the walls. They'll show this is how much patients we saw. This is our quality measures. So that's a very transparent improvement initiative. Pre-visit checks. So before the patient goes, you already know who's coming in this week and what they're due for before they even get there. And then finally, it's capacity. What resources can we reach? Once you get to that, you get to phase 3, where phase 3, we start to spread it throughout the organization. So I'll show you kind of how some of this looks. Next slide. So whenever you kind of get into these moments where, all right, we're going to go out and we're going to try and improve something here. Everyone goes to the conference and they come back with all the great ideas, and it's like you come back to your organization and it's like you're a balloon and you're walking through and they just pop it immediately, right? So we get into this idea like, yeah, we're going to do this. Well, the very first phase you move into from the idea phase, the ideology phase, is you move into conflict, the competition of ideas. You move into what we call the storming phase. If you guys can push through that phase, you'll eventually normalize and you'll eventually start to perform. Just know that this is the natural trend of how it works. Next slide. So in Alaska, we had an issue. We knew what the issue was because of our Centers of Epidemiology. Dr. Provost really put together a very comprehensive package of what was going on in our Native communities up there. So we knew what the problem was. The problem was cancer, particularly colon cancer. It's very hard to get these things done when these very rural communities, because of all the logistics involved with it. So we said, all right, how are we going to attack this? What does this look like? What tweaks are we going to make to our systems? What tweaks are we going to make to our processes? What roles and responsibilities are we going to change to kind of go after this number and see what we can do with it? So next slide. So training was number 1. So literally getting every single person in the room and going over, here's what we're doing. And that's not just every person. This is also the nursing director, the chief nursing officer, the PRC folks. This is all the case managers and care coordinators, and they're also coming in on a Saturday. So when we looked at that one slide where it says leadership buy-in, this is them buying into a belief that, hey, we need to get trained on these tools, how to use these tools to the fullest in our best capacity, and we're willing to put in the time, even on the weekends, to get it done. Next slide. So here is, you remember one of the other things we were talking about, communication plan. What does that look like? Well, here they are doing a nurse huddle. They're basically going over the measure of the month. This happened to be Breast Cancer Awareness Month, which is getting ready to come up in a couple of days here. And they're basically saying, all right, here's who we got coming in. The mammo schedules are open. Let's start referring them over there to get those mammos done as they're due. Basically doing a quick 15-minute brief to keep everybody aligned on what their quality focus is for that day. Next slide. So care team, right? So I know you guys are not going to be able to do this. This is South Central Foundation in Alaska. They have a lot of money, so they're able to like hire their way out of problems, if you will. You won't have anything like this, but this gives you an idea of what it could look like. So you have the primary care provider, which is kind of acting as the team lead. You have the RN case manager, so they're managing referrals, they're managing consults, they're getting the information back into the system. Now, this is crazy because that RN case manager is so important that they actually have a support person with them too. So making phone calls, going over results, getting paperwork put back into the EHR. They embed behavioral health consultants. So if you're a provider, you go in, or you're an RN or an MA and you go in and you get a positive depression screen, you quickly have a warm handoff. They include dietitians in their pods, and they also have, a lot of times you'll even see working with 2 teams, maybe a pharmacist doing medication reconciliation and stuff like that. Next slide. So that kind of gives you an idea of configurations of care teams, and I have like 20 or 30 different configurations. I can kind of share them with you guys. But this is automizing your care system. So whatever EHR you're working with, whether it's GE, Centricity, Greenway, Epic, Cerner, RPMS, a lot of times if there's these repetitive motions, like every year, you're going to do back to school exams, for sports every year, you can most likely make templates that will speed that process up. In our RPMS, for example, we have quick notes. We can tie that in to a dialogue just like this. So anywhere in EHR, you can click that quick note and it'll pull this up. So this right here is where we get our Gipper credits. So this is an example. This is an example from a Gipper Screening bundle of a site here in Arizona. And so what happens is their MAs actually do this whole first top part. So they do the tobacco use, Rocky Mountain spotted fever. They do activity levels, alcohol screen, depression, domestic violence, health literacy, because they're a certified patient-centered medical home, so they have to include that. And then they look to see when was their last nephropathy, and do we need to do a monofilament. Then they have a whole second level of screens where they can go in and the doctors can come in, or somebody with maybe a higher licensure can come in and do some of the more aggressive ones. And that's what you see at the bottom there. So they practice really good SBAR communication between the nurses, MAs, and the doctors, and they get all these done. The important thing is they're actually clicking in the right places. And this is where we get our Gipper credits. Next slide. So here's an example of a template that was created for a note. So this is them trying to work smarter. So what they're doing right here is they're pulling in information that they've already entered. So they're using their IPL, their integrated problem list, and they're putting their goals and treatment plans in there. And that's actually pulling into the note so they can see what they spoke to the person about last visit. They were here, and it's pulling all into their SOAP. So again, this is them trying to work smarter, instead of harder. So it's doing half the work for them. Next. So in a lot of EHRs nowadays, they're inserting clinical decision support is what we call it. But basically it thinks for you, it chart reviews for you. It goes through and says, this person is this age, or this person has this diagnosis, and I don't see the diabetic eye. This person is in this age range, but I don't see fecal occult or colon cancer screening, tobacco screen, etc. So if we just do the red clocks, if we just do those reminders and those clinical decision of support, you will see your measures, your quality measures go up. So let's start questioning and using the tools that we have to the best of their ability. Next slide. And so we have in most electronic health records, there is multiple places. Just like in Microsoft Office, you have multiple places. You can Control-C to copy, you can highlight it, right-click. There's multiple places to enter things. So here you have multiple places where it's showing you not only is it a red clock saying you're due, but over here you also have on the dashboard, it's telling you what the patient's due for. So most of these EHRs have multiple instances where they're literally telling us what to do. If we just listen, we will improve our quality measures. Next slide. So then a lot of times we can take these tools and they are getting smarter and smarter every year. So we can sort for things. So we can say show me all the females that live in this community that are due for a mammo. We have a mammo van that's driving out there and we want to call them up and get them appointments before they get there. So you got to get crafty in Indian health. So you got to come up with strategies and come up with ways. So how do we identify these people outside our doors? So the EHRs are helping us take care of the patients who are coming through our doors, but what are we doing to take care of the patients that aren't coming through our doors? And we do have tools that can do that. Next slide. And so then what they'll do, normally, my question is, can you get it into like an Excel spreadsheet? Because almost all the applications out there, whether it's Doximity or it's Tiger Text or it's Care Message or any of these tools, especially that since the pandemic came out, these tools all now function off of delineated or Excel spreadsheets where you can just drag and drop them in and then send out a text message to everybody. So next. And I'll kind of show you this is just one example, right? I think this is Care Message, and Little Traverse Bay Band is using Care Message. And so what they'll do is they'll send out like CDC recommendations, or hey, we got the new flu shot, or hey, come on by, you're high risk and you're due for a booster. They'll use these tools. These tools are getting smarter and smarter. So all this is working off of is an Excel spreadsheet. And it'll actually tell you how many people received this, which phone numbers didn't receive this. So now you can go back and say, oh, let's remove that phone number from registration. So when that patient comes in, we'll get a new one. You could even have responses and stuff like that on here. Next slide. So here's another one, another example. So inside a lot of these tools, you can actually target, hey, let's do one just for women over the age of 50 about mammals. Let's do one on colon cancer. Let's do one on, we're having a syphilis outbreak in our neighborhood here. So let's send that out. All right, next slide. So going back to colon cancer, right? So we applied multiple strategies to do this. So we redesigned our care teams. We created what we call case managers and care coordinators. So they're really getting focused on getting those appointments outside, making sure the patient shows up to those appointments, making sure they have the vouchers to get back or the taxi and the hotel and all that good stuff. We literally created roles that would focus on that because we were not doing good at taking care of the patients outside our doors and they were slipping through the cracks. We also looked at everything that we can automate in the EHR. We also trained everybody how to use these tools, trained them, here's where you click to get credit for this, here's where we get our Gipper. And within a 2-year time frame, we went from screening at 10% to now these guys consistently screen at over 80%. So you guys know in healthcare that if you take 100 patients, you're gonna have about an 8 to 10% finding just for colon cancer alone. So that means if you're screening 2,000 to 3,000 patients more than what you were, you're getting a lot of early diagnosis, early detections, which at the end of the day is saving lives. And that's what this is all about. Next slide. So after we did that, we started to actually publish articles on it. And you could see that they were really key back then, particularly back in the 2010 timeframe, 2007. They wanted to have like an EHR win. So they were saying, oh, it's because you guys adopted the electronic health record. That's how good you're good. But that was not 100% true. Now, obviously, these measures did go up, but we did a whole bunch of other things. And that's what I'm kind of stressing to you guys. What does that look like? All right, next slide. So we started to publish these things, and they kept trying to push it back towards, well, you got electronic reminders, and you got this clinical decision support tools. And we kept coming back saying, no, we actually did, we created a new job called case manager. There are whole roles and responsibilities. So we kind of talk about all the things we did to not only the electronic health record and doing this, but all the thinking that went into it and everybody going all out and everybody full steam ahead. So next article. So then here's, this is us going more into the day-to-day, like the care team configuration, the process analysis, the gap analysis that we did. And so that was for the Improving Patient Care Initiative. Next slide. So the question is, and I stole this from my wife. She's a school teacher. She has it up on her wall. And so I absolutely love it. But it's a, what do they call that? A flow map, process map. Are you happy? No. Do you want to be happy? Yes. Change something. And vice versa. Are you happy? No. Do you want to be happy? No. Keep doing whatever you're doing. So a lot of times what our organizations will do is we'll kind of get stuck in these places where we just keep doing the same thing over and over again and just kind of continue on, semi-dysfunctional, if you will, this is how we always did it. And we got to mentally say, what are we going to change? What does that look like? How do we know that change is going to lead to improvement? Next slide. So this is the model for improvement. So this is kind of what I was talking about, right? What are you trying to do? What is your aim? And be specific. Like, we want to get depression screening rates to 60% by 2020, November 2023. And this is how we are going to do it. What are we going to measure to know that those changes are working? How are we going to keep track and document that? And then again, plan, do, study, act. You guys probably heard this before, but that's just the basics of getting together, planning what you're going to do, executing it, studying the results, those measurements, and deciding what pivots you're going to take. Next slide. So this is what a form looks like. You just literally type up PDSA. So now you're having your meetings and you get together and you say, all right, here we are, our improvement team or whatever. What are we going to focus on? We're focusing on the measure of the month, breast cancer awareness. All right, what are we going to do? We're going to send lists of patients that are due out. We're going to send letters out. We're going to send text messages out using care message. We're going to look and comb our schedules for tomorrow and make sure that the people who are coming through have all been up to date. So you come up with a plan, you execute, and then you study and you look at the numbers and see if they're going up. Next slide. So here's that focus, right? And I can share I can share with you guys a measure of the month. We call it MOM, and it basically has every single Gipper measure and what it ties in with naturally. So here's them focusing on, hold on, I gotta move the little picture here. It looks like they're focusing on alcohol. Have they been screened? Yes. Have they had that expert education? No. So we now know who they are, who is coming in this week, and who we need to educate on that. Next slide. So here are those processes I was talking about earlier, where can we make a list of this? Can we put this in one-stop shopping to where we just boom, 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 boom? Think about this for like nutrition. Think about this for diabetes. We put all the educations together and we can just do them all from one place. Also, like prenatal is another one. They have like first trimester, second trimester, and there's like a ton of educations you have to do that you'll never know unless you have something like this. Next slide. And then it will get into the right places. So when we see this lighting up with blue, and we now know that this is attached to an exam code, and that is what the Gipper logic is looking for. It's looking for either a CPT code, a HCPCS code, an ICD code, or looking for an exam code like these education codes right here. Next slide. So when you start to put all these pieces of the puzzle together, you'll start to notice changes in your system. So this is going back to the measurement. So here we were able to demonstrate that outpatient department productivity increased year over year. So just by being more efficient, they were able to see more patients. Next slide. Because of this, because you could actually get in to see your primary care provider, guess what happens? Your no-show rates go down. If you are scheduling an appointment and they're saying, we can't get you in for 3 weeks, what do you think is going to happen by 3 weeks? You think you're going to show up to that appointment they gave you? No, you're probably going to get care elsewhere, or by then you're already healed up. So yeah, your no-show rates will go down. Next slide. We were able to demonstrate that, like this one, for example, San Carlos Apache Health Corporation, they were able to go from meeting 3 Gipper measures to the very next year meeting 24 to eventually meeting even more. So they, in a short amount of time, making these changes, they totally were able to leverage it and get outcomes which you're seeing. Next slide. Oh, and guess what else happens if you start being more efficient and start getting the patients in when they want to be seen? They get happier. So patient satisfaction goes from 50% to like 95. And then you'll know you got perfect, you're getting that engagement because they'll start putting comments and they'll call people out. And that's exactly what you're seeing here. They're literally calling out care team members, case managers, care coordinators, nurses, MAs. I see it all the time. They start getting this positive feedback. So next slide. So when we look at the IHI, they call this the triple domain, or multiple different names, but we're able to improve the experience of care. We're able to improve the per capita costs and effectiveness of our care system. And we're also able to demonstrate population health quality measures that are improving. And that's kind of how you guys want to approach these projects. Next slide. That's it. So I think I was 32 minutes, guys. Thank you for having me.
Thank you so much, James, for that presentation. So now we would like to move into our open discussion, which is definitely for all of our UIOs to take advantage of. And feel free to add any questions or comments into the chat box or come off mute. We definitely encourage that. But if you have, any questions or you're facing challenges with certain aspects of HIT or EHR, definitely take the opportunity now to talk with James.
We got a hand up, Nicole.
Hi, yes, so I'm Nicole Brewer-Lowry, and I'm the Psych Director for the Native American Lifelines in Boston. We have an office in Boston and in Baltimore. We are currently using therapy notes, but trying to transition over to RPMS. We are finding, because we don't have someone on the team who is, our IT person, we are having issues with just trying to get someone to help us know what all the infrastructure we need. And then we are working with someone on starting up our RPMS, but we're kind of in a place of being stuck. So I was wondering if you have any advice on how we can get over that hurdle of making sure, one, we have the correct, computers in place. And then two, how do we get everyone properly trained for RPMS?
So yeah, so there is documentation that we can share with you on what are the bare minimum requirements of a server, what version do you have to be on, so right now everyone's pretty much on a version of 2012 Microsoft Windows Server to use the new Ensemble, and then once you get that on there, it's a matter, you can go to ihs.gov and download you can download RPMS right from there. So they actually have all the patches and all that stuff downloadable there. So then it's just a matter of installing on the individual machines, or having a terminal server that you have there. But we can help you with that. I can get you the documentation of what you need. Not very much stuff, believe it or not. And then it's a matter of just getting folks trained. And so as you see, when you do group training, like those slides I was showing you back there, that's the best way to do it. Just kind of get everybody in the room. They all do it. They sign off on it. You also do a competency form. So they sign off that they know how to, they know how to enter this, they know how to put this in. And then so later on, they can say, no one ever showed me. It's well, you ordered a consult before. We have you signed it. So does that help?
Yes, that's very helpful. I would love to connect with you and get our executive director in conversation to see if we can move past this hurdle.
Awesome. Anyone else?
Looks like there's another response in the chat from Joe. So this might be a question asked before, but has there ever been discussion of developing a UIO cooperative to potentially leverage for supporting each other in such things as group rates for an EHR provider, or even employee benefits at a larger group rate?
I like the way Joe thinks. You guys would probably be better at answering that than me. Not that I know of, no.
Yeah, I could tap Zep on the line to see if she has any more on that subject.
Yeah, I think especially you guys Nikui could almost create a center of excellence where you start gathering the resources and folks like me, and then that way we can have these offerings. I think you guys are taking a step in the right direction right now.
Hi, everybody. My name is Zipporah Fuller. I'm the Director of Technical Assistance here at Nikui. And so just to clarify, the question is coming from a Mr. Joe about the potential group rate for EHR providers and employee benefits at larger group rates. Yeah, that's kind of a tough question just because everybody has a different preference, and commercial off-the-shelf vendors right now, and depending on what sort of facility type you are, we do have 4. We've got the full ambulatory, the limited ambulatory, the referral treatment centers, the residential treatment centers, and then the outreach and referral facility types as well. So to kind of have a vendor that addresses all of those needs, especially if it's a medical, like clinical EHR, probably wouldn't be helpful for the outreach and referral team. So just trying to think through that. Right now, our focus is really trying to, think about what the data looks like right now. In terms of trying to streamline it, because you guys have the IHS UDS, the HRSA UDS, the Gipper, SDPI as well. So trying to advocate so that way we can try and streamline those metrics, and then try and utilize like a really great system of methodology. I know that IHS also has kind of their logic inside of their reports as well. So, maybe that is a great question for future reference. But, as we know, IHS has been moving toward trying to move our PMS onto Cerner as well. So that might also be helpful, since Cerner is built to be a little bit more interoperable than, our PMS is right now. So that's kind of the, I guess, drawback. And the other item too is that when switching to a commercial vendor, the only data that's able to migrate from RPMS is just the demographics. Everything else has to be manually input when switching to a commercial vendor. So that's the other kind of major lift, if you will, for any sort of group transference or what have you.
Thank you, Zeb.
Yeah, I'll just add a little to that real quick. When you guys are looking at, just to keep in the back of your mind, because I've done a lot of migrations of EHRs to different vendors and et cetera. And one thing they'll always show you is they'll show you how great it is at documenting or how great the tool is. But the good question for you guys to know and to always ask, and this is what a good IT will ask, is about interconnectivity. I want to know, how well does it connect to the lab? How well does it connect to pharmacy? How well does it connect to radiology? How well does it connect to, my imager? That's the stuff that you got to really look at when you're looking at setting up electronic health records, is the interconnectivity. Anything else?
Yeah, and just to help maybe spark some of the items that were mentioned before. So there were notes of, needing some more assistance with reporting, such as Gipper, if there were, training or resources in regard to the CAC role. And then also there was note of compliance in regard to HIPAA. So I'm just wondering if anyone on the call has anything, that touches those subjects, or even if there's something else, definitely utilize the time. This is for you.
What was the compliance and HIPAA question?
One second. So yes, we did have someone talk about TA surrounding the development of HIPAA compliancy policies, procedures, scenarios, and tailoring trainings. that would help
Okay.
improve staff competency.
Okay, yeah. So a lot of those offers are, you can actually get these things online now. A lot of these are offerings that you can get training online and for your employees. And, you know, there's different types of tools like Health Share or, you know, companies that do that. I also have a lot of policies and procedures. So all the years of working with federal sites and tribal sites and urbans, I always try to, especially if we're making them from scratch, I always try to keep all the policies and procedures. So I have a whole folder that is just, what do you do with a critical lab? What do you do with the, you know, what's the process for this, that? I can also share some of that too, but a lot of that's already out there with various tools like Policy Wizard and, you know, Health Share and stuff like that. Yeah, we can send like a policy template, like a Word, one that's like a Word document. You just see how what other folks look like.
And Tiffany, if you could repeat that question for me so I can answer it from an accreditation, a regulatory standpoint.
Oh, yes, I was putting it in the chat for you too. But it was TA surrounding the development of HIPAA compliancy policies, procedures, scenarios, and trainings that will help improve staff competency. And then also there was note of compliance with AAAHC.
Oh,
Yeah.
yes, absolutely. So we do have several trainings regarding the AAAHC. So I used to be the quality improvement coordinator at Native Health for 4 years. And so a lot of my job at that time was to develop policies and procedures for Native Health in compliance with the AAAHC, HRSA, and OUIHP as well. And so the great thing about AAAHC is that there's actually a contract, I believe it's expiring at the end of this year with OUIHP. So if you guys are interested in obtaining information about it, I believe they're going to be hosting their virtual AAAHC conference as well. I did see Taryn is on the line as well, so please correct me if I'm wrong, Taryn. But I know that UIOs can also submit a contract request to Debbie Norwood, who is able to connect your UIO to the AAAHC IHS contract contact. And through that partnership, you're actually able to perform like a mock survey assessment and also speak with a AAAHC consultant as well, who can give you a huge timeline and checklist of all the policies that you're going to need. They'll also work directly with you so that your staff can attend that AAAHC conference at a contracted rate or free rate, and also give you access to their safety toolkits as well. And then in addition to that, I did post the link for TA helps request in the chat box too. So we also are able to assist you all with policy support as well. And it doesn't have to be just in HIT EHR. We do have folks who do specialize in infection prevention and control. We do have nurses on staff as well as quality improvement staff as well. So if there's any other policies, procedures, AAAHC needs that you might need, definitely feel free to submit a request through that TA request form.
Thanks so much, Zep. Anyone else have any other questions for support? Again, this is definitely your time to ask James or Zep or anybody in regard to HIT and EHR. Okay, if not, we could definitely advance, but we will be seeing, oh, there is one. So is there a possibility of putting together a list of sites and what EHR they are using to potentially build working groups of organizations using the same systems? That is a good question.
Yeah, that really is a good question. One of the first things I do when a site says, hey, we want to go try this EHR, or we want to look at that, I try to find them another place that's already on it so they can hear the pros and the cons. I try to make those connections, because the sales folks ain't going to tell you the truth, but that other group will tell you the truth. So they'll be like, oh, this is the stumbling blocks we went into, and this is how we resolved it, and this is what we did. So it's always good to make those connections. That's a great question.
Yeah, and I can go ahead and chime in. So Nikui actually already does have a UIO profiles list in which we have this together. And so a part of our initial approach is to host these events such as this under Tiffani's great leadership to have this HIT HIT support and try to find out kind of how we can organize this. So we're actually starting out with you all. So the more questions you guys answer, the more attendance you guys have, the more you are sharing with us what your needs are, we can begin building these tailored groups so that you guys can have, your own EHR work groups. And so I definitely would encourage you to keep coming to these. And if there are questions that you have, please feel free to continue asking them. But that is our goal to work toward next. So you're definitely right on target. So thank you so much for that question.
Hello, this is Angela from Native Health. A quick question. Do you have resources for HIT certification for UIHOs for free or at a reduced cost?
Hi, Angela. Great to see you, or hear you, I should say. Yeah, we definitely can compile a list together. Right now, the only list we have for that, for any sort of certification for UIOs, is for infection prevention and control. But we are compiling a list to try and see what we can work on, in addition to working with IHS to see what they'll also offer as well. So we're definitely in close contact with our IHS team. And also just trying to see where we can develop, those free content for professional development, as well as sharing, the upcoming CAC training as well that just went out in our recent newsletter. So we definitely have a lot of really great resources that'll be upcoming.
Thank you.
You're welcome.
Thanks so much. Anybody else?
Yeah, I think that one of the things that I would highly recommend is that like with an organization, like if they were to like work with me and say something like, hey, we want to have CAC support from you, one of the first things I would recommend is that it's actually better if you give me somebody to train as a CAC, and so you can build that capacity in-house rather than be dependent. So you want to build those clinical applications coordinators, that technical stuff with your own people, is what I'm basically saying. So that's far more effective. And I got all the CAC training materials. If you guys ever want it, you can download it online. So.
Great, thank you so much. Anyone else willing to share? Well, no pressure. We could proceed with the presentation, and then definitely keep monitoring the chat for any other questions, or feel free to come off mute. But we would like to have that reminder put up for our evaluation, which will definitely help us identify those needs for HIT and EHR to better support you in the work that you're doing. And Micah did put the link in the chat for you as well. And also the QR code is there. So if you wanted to pull out your phone and turn on the camera and hover over that, that will bring you right to it as well. And we also have the link for the IHS EEHC partnership. Thank you, Zep, for providing that in the chat. And then also to mention too, it was mentioned earlier, but if you would like to have that one-on-one training with James on anything HIT or EHR, you could definitely feel free to submit the technical assistance form. And Micah could put that in the chat as well. Next slide. And we'd also like to mention our upcoming Nikui events and funding opportunities. So we do have a save the date for the next HIT session, a gathering of people on October 19th from 2 to 3 p.m. Eastern Standard Time. And James will also be on that as well. And then we also have our emergency preparedness and vaccination planning storyteller application that is open through the 30th of this month. Next slide, please. And so we would like to thank you all for your time. We truly appreciate you joining and providing to the discussion so we could better help assist you with your needs and challenges with EHR and HIT. So I would like to open it up for any final questions or comments that you would have. And if not, no worries. We also will be providing the slides and resources following today's presentation. But thank you again. And we will hang tight on this call for a little bit in case there's any questions or anything that pops up. But thank you again and have a good rest of your day. We look forward to seeing you on the next call.